wherever you are joining us from. Oh, okay, I'll start again. That was the jingle. Good morning, Berlin. Good morning for wherever you are joining us today, or also if you're watching the recording. We have around 4,000 people here in person today in Berlin, and I think over 10,000 people who follow the World Health Summit live on live stream, and hopefully many, many more who will follow our recordings. So welcome to the most important session of the whole summit. I'm really glad you chose this one. There's a lot of parallel sessions going on. The World Health Summit, you might be very well familiar with. Many of us here in the room and following today might have been in Berlin a couple of months ago. There was another very important summit, a global summit on disability. And we'll be talking about both of these and the interlinkages today. Why is this session important? I'd like to start with this point. I'm going to quote the International Disability and Development Consortium, the IDDC, which we are also all members of. Cuts in official development assistance and foreign aid, negative narrative towards diversity, equality, and inclusion, and the ever-shrinking space for civil society are setting back the fight for human rights, and especially for disability rights, decades back. That's quite a shocking statement, and if you follow anything in global politics, also in national and social politics, this will be familiar with you, but I think it's important to emphasize this. So we're here today to discuss how health systems exclude 1 in 6 people and what we can do about it, because we're not hopeless, we are not without plans, and we are here together as a community with a will and a plan to act. So thank you again for being part of this. My name is Katri Bertram. I have the pleasure to moderate and chair a really, really fabulous set of speakers and panelists here today, and I'll introduce all of them shortly. You have on your seats a puzzle piece. So you might have been asking yourself, what am I sitting on? Why is it feeling a bit uncomfortable? Take the puzzle piece into your hand, grab hold of it. You will find out the solution to the puzzle as we move forward. And this is something that you can also keep and take with you as a memory of why this session was great and important and inspiring. You will also on your seats find a couple of leaflets. Please also feel free to take them with you. For social media, you will find all handles, and also for all speakers, the LinkedIn tags. So please do feel to post live from the session as well today, or after the session. We'd love to hear your thoughts on social media as well, what this triggered and what kind of action you have decided to take. There's also a QR code on the white sheet on your seats. We will be working with Mentimeter. This is a tool to gather your thoughts and get a bit of a perspective of who is in our audience here in the room. So you can also already, in the meantime, take out your phone, photograph the QR code. There's also a link that you can use. And if it is too far on the screen, you can also use the sheet on your seats to get access to the QR code. All right, I'm going to start with a first Mentimeter, and thank you to Miriam, one of our session organizers here as well, who's going to be walking us through a first question. So please get ready on your phones. If you have any access issues, problems joining, just raise your hand and we'll come and help you. Good. So the first question is, where are you from? Germany, Finland, that's my home country. Good to see somebody from Finland. Iraq, UK, Nigeria, Liverpool, I like Liverpool, Austria, Apollo, Tanzania, Nigeria, India, Ukraine, Austria, Zurich, Malaysia, Nigeria, Nicaragua, Cameroon, Burundi. Wow, we are a very diverse group of participants here today. Great to have you here with us. Yemen, USA. Thank you so much. All right, I'm going to start with the part I am most excited about today, which is to hear an impact statement, an opening speech by a colleague who is sitting here next to us. Valentino Vergotin is a Special Olympics athlete from South Africa. He's won several gold medals and silver medals. So, congratulations, kudos. And Valentino is a board member of Special Olympics South Africa and a health messenger. In his spare time, Valentino also teaches school students and fellow Special Olympic athletes how to swim at a local club. And as a former swimming trainee, we were just catching up on, what a feat and what an effort and dedication it takes to swim and to succeed as amazingly as you have. Valentino, over to you for your opening remarks.
Good morning, ladies and gentlemen. My name is Valentino Bertram. I'm a Special Olympics South Africa athlete leader, and also a board member, a swimming coach, and a health messenger. Where it all started, one day me and my older sister went to a community pool where she decided I must go swim in the baby pool, and she was swimming in the big pool. I decided on myself, no, why must I go and swim in the baby pool and she must swim in the big pool? So I jump out at the baby pool, jump into the big pool. And then from the top, I went to the bottom of the pool. The lifeguard saved me, and my sister saw the whole story, what happened to me. We went back home. She told the story to my mom, what happened to me at the community pool. The Monday, we went back to that same pool where I almost drowned it and learn to swim it. I started at Bethel School in grade 4, where I got involved with Special Olympics South Africa in 2004. In 2005, I was the first colored boy who presented Bethel School for South Africa, who qualified for the 100, 200 meter breaststroke. I present my first time at the World Summer Games in China, where I won 2 gold medals and 1 silver medal. I got the second opportunity in 2011, present Special Olympics at the World Summer Games in Greece, where I won 2 gold medals. That same year, I broke the SA record in the 200 meter breaststroke. I'm with Special Olympics for 20 years life. I got the opportunity to meet the president of South Africa. My health journey, my life experience, no support. People do not see my disability because I've got both my arms and both my legs. And also I've got the able body, but they forget, like, I have a problem with reading and writing. Need assistance with forms at the day hospital or clinic. Sometimes my mom is with me, sometimes my mom isn't with me. Sometimes I must ask the lady or the receptionist to help me with the forms, like, she will look at me like that, like, what is wrong with you? How old are you? Can't you read or write? I'm like, no, I have a disability of reading and writing. Then I need to explain to her, like, and then she will understand. Doctors do not explain any of the medicines or tablets what they gave me. My joint pain, 2024. One day I couldn't. When I got up, I couldn't stand. I couldn't walk. I couldn't lift up my arms. My elbows was like tennis elbow. I told my mom I'm under pain and we need to go to our nearest day hospital or hospital. So we decided to go. We're waiting for a couple of hours there at the day hospital. So I saw there was two queues, one for able bodies, one for old age pension and disability. So I decided, okay, I've got a disability, let me go stand in the disability queue. The nurse and one of the able-bodied people who were sitting at the day hospital came to me and say, what is wrong with you? Why are you standing in the queue line? So I'm like, sorry, I might have both my arms and both my legs, like, but I've got a disability of myself, like, I've got a reading and writing problem, so I need to stand here, like, and so they understand that, like. So I was still waiting in that queue for 2 hours or so, waiting for to see the doctor. Got the opportunity to see the doctor, explained to him I can't stand, I can't walk properly, I can't lift up my arms high, like, and my got tennis elbows, like. So he decided to take blood testing, and it took forever, like up to 6 weeks for my results to come back. But between that, we were constantly phoning the day hospital back and forward to hear if they got my results back, because I was still sitting with that pain, like, and couldn't go forward with life. So luckily at the 6 weeks, he phoned me and said he got the results back. We went back to that same day hospital and the same doctor. So he got my results, he diagnosed me, I've got gout, cholesterol, and also I've got lots of acid in my body. So he gave me 6 months subscription of tablets to use. I used it for 6 months. So after the 6 months, I went back to him at that same place. Luckily, it went quicker. I didn't stand in that same queue so long or waited for him, like. The results came back. So luckily, there was also a second doctor who also were there checking out my results. The second doctor said, but there was nothing wrong with you, like. I'm like, but this was the doctor that when I saw the first time, he diagnosed me, I've got gout, cholesterol, and also I've got lots of acid in my body. So he gave me the tablets to use for 6 months. So he's like, but there was nothing wrong, like. So after that, when I heard that, I stopped immediately using the tablets. Okay. Looking back, I'm a qualified level 1 swimming coach. I want to give back to special needs swimming kids. And to end off, I have one good reason. I've got one good experience and one bad experience at that same hospital. This is because there are problems with the system. There are problems to solution this. We need to work on a report calling, focusing the ability people like me and also the vision of challenges. Thank you so much.
Thank you so much, Valentino, for sharing your journey. And I think I'll pull out a couple of points. One is, don't change the person, change the system, a very important point. And the second is, again and again, I can just underscore how important it is to hear about the lived experiences firsthand. A health system that often tries to include people with disabilities in the abstract thinks of things like ramps, maybe Braille for information materials, but doesn't think of the whole spectrum of diversity that there is in the disability community as well. So thank you so much for sharing your lessons and also the inspiration and how you turn this into such a positive and constructive momentum. Thank you. I'm happy to welcome Dr. Rüdiger Vorwerk from the German Federal Ministry of Economic Cooperation and Development, BMZ. She heads the subdivision of Economy, Trade, Employment, and Digitalization. And I saw from her bio as well that she headed a team that developed a proposal for the SDG agenda way back under Ban Ki-moon's leadership as well. So, wow, what a different world it was back then. We look forward to your opening key remarks. Thanks for being with us.
Thank you so much, Mrs. Bertram, for your kind words, and dear Mr. Bergstein, thank you for setting the scene. So I'm here in an official position now, but on a personal note, I know the stories very well because my own brother needs a lot of support. So I think many families have these kind of experiences in their lives, in their group of friends. So it's something which many people know. So I'm glad to be here and very appreciate to invite me. Imagine a young man with an intellectual disability, let's call him Paolo. He cannot find any understandable information to learn more about his health. Doctors and nurses, and it's quite similar what we just heard, do not talk to him. Medical decisions about him are taken without him. Imagine a woman who is excited to be pregnant with her first child. Let's call her Sarah. Midwives and doctors do not know how to take care of her because of her disability. They make her feel like she should not even have a baby and send her back home to give birth. Situations like this are a reality for a person with disabilities all over the world. Healthcare is often out of their reach. Even when health services are available for them, persons with disabilities tend to receive medical care of lower quality. As a result, people with disabilities live 10 to 20 years less. This is very different, and with a lower quality of life. This is a reality we cannot accept. To overcome these inequalities like these, Germany hosted the Global Disability Summit. We have just talked about it 6 months ago, together with the International Disability Alliance and the Kingdom of Jordan. The summit conducted with the Amman Berlin Declaration, for the first time ever, a global quantifiable target for disability inclusion was set. So really a political milestone. The ambition 15 for the 15 targets stipulated that 2028 at least 15% of international development programs at country level should focus on disability inclusion. 100 signatories have already committed to this goal, including national governments, UN entities, regional organizations, and development banks. Through those commitments, the global community is taking a significant step forward in advancing the UN Convention on the Rights of Persons with Disabilities. At the Global Disability Summit, an impressive 820 commitments were made, financial pledges and concrete actions to address disability inclusion gaps in national policies and international cooperation. On health equity, 73 commitments were submitted. They came from government, civil society, multilateral organizations, the private sector, academia, and organizations of persons with disabilities. And this reflects, this is my perspective, an urgent needed whole of society push for disability inclusion in health services. These commitments aim to deliver real change for persons with disabilities, including better access to health services and facilities, especially for women and girls, and better skills among health personnel. In the run-up to the next Global Disability Summit that will take place in 2028, we have to hold ourselves accountable to deliver on those commitments. With regard to the Amman Berlin Declaration, the message is clear. GDS 2025 has been only the starting point. In order to reach the 15 target, a joint help desk has been established. There, countries can receive technical support to increase inclusion in their international development policies. Germany is committed to lead by example. BMZ has increased the share of disability inclusion programs from 4% in 2022 to 15% in 2024 and aims to reach 20% already this year. So we invest in training from community health workers and exchanges between hospitals to make health services more disability inclusive. Moreover, many of BMZ's key priorities in global health contribute to improve the inclusion of persons with disabilities, to change Paolo's and Zara's stories to the better. Going forward, cooperation between global health and inclusion actors, as well as across sector, will be the key to bring health equity for persons with disabilities forward. Multi-actor platforms like the WHO Disability Health Equity Network are an important step in this direction. I would like to thank the organizers for this session on the first day of the World Health Summit. It's amazing for giving disability inclusion a platform at the World Health Summit, and it's an important opportunity to learn from each other and to talk within the next days with many people about these needs and activities. Have a good day and have a good session. Thank you so much.
Thank you so much, Dr. Forbeck, and I think some very important points there as well. Why is this session called 1 in 6 persons are excluded? 1 in 6 people in the world globally have a severe disability. And if you take psychosocial and mental disabilities into that equation, it's closer to 40, even 50%. So I think we've said this several times over the years. It's not a niche issue. This is not just something that affects people somewhere out there. As Ms. Forbeck said, it's often very much close to your homes, families, communities, and is very, very important. I'm going to hand over to Daryl Bennett from the World Health Organization, who will present a bit more on some of the issues that Dr. Forbeck as well mentioned, a health equity network, and a lot of the action we would like to see you get involved in as well. Daryl is the head of the Global Disability Program at the WHO in Geneva, where he spearheads the development of transformative policies, advocacy initiatives, and capacity building efforts. Daryl, in his work, tackles complex legal and governance challenges while keeping the voices of marginalized populations at the center. So not everybody at the WHO just does clinical practice and is a doctor, as we will hear. Thanks, Daryl. Over to you.
Thanks, Katri. No, I'm not a doctor, but thank you for that lovely welcome. And hello, friends and colleagues. As Katri said, I'm here to talk about WHO's new global initiative on health equity for persons with disabilities. I was thinking about having a dramatic start to the presentation because that's what you're supposed to do when you present. And I found myself getting frustrated because I kept coming back to the same position. This presentation marks about the 48th presentation that I've given on health equity for persons with disabilities. And I think it's just better. Sorry, I need the clicker. We practiced for this and I have forgotten about the clicker. I think I'm going to let the numbers speak for themselves. As we've heard, people with disability are dying up to 20 years before the rest of the population. Now, as global health actors, that should be enough to stop us in our tracks and ask, what are we doing wrong? But on top of that, we see across the board poor health outcomes for people with disability. And essentially, that's due not to a person's underlying health condition primarily, but it's due to a range of factors both inside and outside of the health system that we can change, that we can present. So we know what the issues are, but we also know what we need to change. And it's great to just follow on from Germany's excellent presentation about what they are committed to doing. But we need a lot more. We need every member state who in 2021 backed the World Health Assembly resolution on the highest attainable standard of health for persons with disabilities to actually take action now and to change their policies and legislation so that we stop discriminating against people with disabilities in the health system. Today's session is really also about building this global movement. It's about recognizing that all of us are often taking steps forward in the health sector. We'll have people talking about their work on assistive technology, and Karen will speak about that soon. We'll hear from organizations of persons with disabilities and how they're really trying to ramp up civil society efforts. We've got colleagues from Gavi who'll speak about their efforts around trying to make sure that they reach unreached populations. But what we've found is that that's not enough because we still have fragmentation as we do more broadly in the health sector. I've put investment for some up there because the reality is millions, if not billions of dollars get invested in the health system, but they don't reach everyone, and particularly they don't reach those who often need it the most. We have the evidence to say that this population group, persons with disabilities, who are represented in every cohort, every village, every town, every city, are often either completely ignored when programs are being designed, or if they are included, it's often not in a way that really boosts their opportunities to have good health outcomes. And again, it's great to have colleagues from Ethiopia here to talk about their efforts in really building leadership, because all of these issues, sadly, culminate in us having health systems that are not fit for purpose when it comes to persons with disabilities. And I don't think that's what any of us who are involved in the health sector want to see. We want to see health systems that reach the people who need it the most. But right now, that's not happening. And so we are on a journey. We are on a journey to ensure health equity for persons with disabilities. And this is not a journey to do something special or nice for a group of people. Remember, this is 16% of the global population. So in every cohort that might need malaria interventions, or every cohort that we're looking at safe maternal care, or every cohort that we're looking at childhood immunization, there is a percentage of persons with disabilities, children and adults, that are just not getting the benefit of our work. So it was actually a year ago on the margins of the summit where we formed a group with very close partners that we've been working with to really ramp up the journey that we're on. And this journey, again, is to transform our health systems into systems that reach people with disabilities as they should. And so in June this year, on the margins of the Conference of States Parties for the Convention on the Rights of Persons with Disabilities, WHO launched the Global Initiative on Health Equity for Persons with Disabilities. And this initiative really marks a broad approach that WHO will take in the work that we're doing on health equity for persons with disabilities. Our mission is to close the avoidable health gaps between persons with disabilities and the general population. We heard from Valentino about some of the issues he faced when trying to access the health system, making sure that information is accessible in different formats, making sure that people with disabilities are not stigmatized above and beyond the stigma that we know exists in health systems more broadly, making sure that premises are accessible. This is the journey that we must take. And again, this is a mission that WHO is applying across our programmatic work. Through our work in countries and our work with partners, this initiative has identified 4 key areas that we need to take action. One is around building the leadership among persons with disabilities so that they can really be represented when decisions are being made in health sector planning. The second is about elevating the political priority for health equity for persons with disabilities. And again, this is not trying to line up our work in disability against investing in maternal care or investing in HIV prevention. It's about making sure that when we do make those investments, that they are disability inclusive, like they should be. The third area is really looking at how we create inclusive health systems. So how do we create models of care that reach people, looking at financing packages, data collection, the very core components of the health system. And the last area is around building the evidence base for what we need to do. Now, I encourage you to scan all the QR codes and have a look on the website, because the approach we're taking is very comprehensive. It has various components, this initiative. One is, of course, really honing in on our work at the national level, trying to support countries to better coordinate the action that they're doing to really reform health systems. And that involves WHO continuing with our normative work of producing standards and guidelines and policies. It will also involve us ramping up our dialogue with the private sector. As more and more private health players get involved in health systems, we need to take advantage of that. And of course, it's about bringing colleagues together to form a network, which I want to talk about now. And this network is essentially a gathering, if you like, of health and disability stakeholders who are committed to working together under a common narrative and a common vision for health equity for persons with disabilities. And the network has three main objectives. The first is for us to really understand what health equity is for persons with disabilities. Many countries and many health actors are still under the impression that if we provide specific services such as rehabilitation or assistive technology, that we've done our job. And as we've heard from Valentino and we'll hear from others, that is part of the picture. And it's great that Karen is here from ATscale, because the work that ATscale is doing in supporting the provision of assistive technology helps build equitable health systems so that people can get the benefits that they need. The second is looking at evidence-based advocacy. Like I said, I've given these presentations time and time again, and they won't stop. I foresee that we'll be continuing to give these presentations for the next couple of years, because we still need to make that political cut through for governments to realize that their investments right now are just not reaching all of the population that they should be. And the third is, of course, enhancing our sharing, our collaboration and knowledge building. And I was speaking to Anna Maria from Gavi just before about, some global health actors are maybe unsure about where to go or what to do. And there are many of us in this room that's what we want to do. We want to support the key global health actors to take some steps to know how to improve health outcomes for people with disability. I want to try and give you an example of what those activities that we might do. Now, these are purely examples. This is not exactly what the network activities will do, but this gives you some idea. So in one of the work streams, which is about the political prioritization, the workstream members might decide, okay, we've got for the next 12 months, we've got to map out where are the key health fora, like the World Health Summit, who's going to be there. We need to target our advocacy and our action so that we can tap in to them doing more on health equity for persons with disabilities. That might be a set of activities for the work stream. We also know that parliamentarians in every single country are really gatekeepers to what governments can or do not invest in. And so getting parliamentarians on board and understanding that health equity is important for persons with disabilities might be another area to work. And then, of course, for the global health actors that are really doing a great job, then we might want to focus on them. The second work stream is really looking at what we might do at a systems level in countries. So it might be that the work stream network members looking at this set of activities might actually select some countries to focus on, or we might select some priority issues. At the Global Disability Summit this year, the biggest area of commitments under health was sexual and reproductive health rights. So that might be a focus of the network. The idea here is just simply to recognize that network members will be harnessed for all of our experience, all of our knowledge, and how we can work together. Now, I've got a couple more slides and then I'll finish up and get the wrap up. But essentially, we launched the network for membership in August this year. It was the most rapid uptake of any alliance that I'm aware of in WHO. We had over 1,000 expressions of interest for joining the network. So far in our due diligence, we've cleared about 260 network organizations, and we have 141 approved members. So you can see they come from a range of places around the world. This is just a snapshot of some of the partners that are in the network or some of the partners that we are working closely with, because it's important to recognize that while WHO has a leadership role in health, we couldn't do this without many of the partners here today, and of course, many more that we will welcome into the network. Second last slide, just to bring us back to why we are here talking about these issues today. It's so that women like Kumba, who has cerebral palsy, doesn't have to shop around to 4 health clinics before she finds someone to help her deliver her baby. Or that Frank, who is deafblind, is able to get the information to protect him from COVID or any other disease that might come across. And then mothers like Fung can get the respectful support from healthcare workers to assist her and her child navigate the health sector. So the 3 things that I want to leave you with as I wrap up is to ask yourself, are you integrating disability inclusion into the work that you do? And if not, why not? I'd love to know why not. The second is, if that's the case, come and meet with us, and not only myself and Kellyanne from WHO, but many of our partners here, and see how we could collaborate together to move the needle in your workspace to take more of an approach that's disability inclusive. And we will be doing another call for the network in 2026, so watch this space, and we look forward to meeting you there. Thank you.
Thank you so much, Daryl. And as a founding member of the network at Light for the World, which is the organization I work for, and also now passed the due diligence test, as many of those 1,000 applicants really want to emphasize how important such a community is to avoid many of the issues Daryl spoke about, the fragmentation in the space, the dire need to make the system work and be fit for purpose. And I think for many of the organizations who do also work in country, the importance of integrating services and making them accessible at primary healthcare level, at care level, and in the communities is so important. They're great accessibility initiatives at tertiary care. They are not accessible if you have a disability with a physical disability or any other disability as well. So just very important points. I'd also like to make a flag. I'm going to see if I can lift it because it is heavy. There is a great report. You can find copies, also slimmer versions. The executive summary is available from WHO's work. It's not that we don't know what to do. I think that is really important to remember. It's about sharing information, really thinking about how does Gavi pick up on including people with disabilities? How does a global fund integrate into malaria programming? How does a German bilateral health system as well do so? As we've heard, there is a commitment to do more. I think it was 4 to 15%. That's a huge ambition to jump to. There are the tools and there's the information to do it. So please make use of that too. We're going to move back to Mentimeter. So take out your phones again and I'll run you through the questions. So the first question is, which stakeholder group do you belong to? We'll see if we get the results. We might need the clicker.
Oh,
Yes.
sorry. Yeah.
Oh, it's still the wrong question. Just
sorry.
a second.
Yeah,
we
okay,
will
sorry.
navigate. Bear with us.
No, the wrong question.
Okay,
No.
we're still where we are. Okay,
Please,
great.
now, yeah.
Hopefully everybody has access to that. So which stakeholder group do you belong to? The options are government entity, civil society organization, organization of person with disabilities, UN agency, academia and education, media and communication, private sector, or philanthropy. We have a lot of civil society organizations, 22 currently leading, quite a bit from academia and education. Yeah, thank you. But we do have, I think, all areas except for media and communication represented here, which is great to see. I do think this is also a testament of who is active in this space, who is active in ensuring services are available or advocated for marginalized person, vulnerable people, and persons of disabilities. We still need to change that fundamentally. We need more government actors, we need more private sector. We need all different stakeholder groups to engage. It's not just an NGO task to do. All right, let's move to the next question. 1 in 6 people worldwide have a disability. Do you identify as a person with a disability? As we heard before, a disability is not always visible. And you also have the options yes, no, I don't know, and prefer not to say. It's very interesting once you start getting into the topic of disability. With age, most of us will have multiple disabilities. So maybe we're all on that way, on that pathway. We have most of our participants as no. So maybe this is also information for the World Health Summit team. Who are we including in these types of gatherings? Who is, the access possible? We also know that it's for some organizations such as our own, it's very costly to bring people with disabilities. You need to bring support staff. There's lots of issues involved. Great. Last question. Do you know someone with disabilities in your family, community, and or work? This is also very interesting once you start reflecting on it, because most of us working in many of our sectors kind of say, no, we don't. But once you start digging into it, you come up with quite a long list. So as we see, it might be a selection bias why you are in this room and participating or working in this area. We have the large majority at yes with 51 and rising participants. Good, thank you. So we are going to, I'm just checking, we don't have another question, correct. Okay, we're going to move to the next segment of our session, and we'll have a bit of movement as I invite the panelists to join me at the tables, and I'm going to move my own materials over. So I'm going to introduce 4 amazing speakers who will be joining us today. The first is Dr. Ebere Okereke. She unfortunately had last-minute travel challenges to make it here on time. So we will have some video input. She was kind enough to record responses to some of our panel questions late last night. So thank you so much, Ebere. I'm sure you're joining us over live stream as well to listen, and then so hopefully soon in person. Ebere is Chief Program Officer at the Mohammed bin Zayed Foundation for Humanity and has over 30 years of experience in global health. She champions equity, inclusion, and African leadership in global health and is a powerful advocate and mentor for women working in global health. Second is Anna Maria Bejar, who has already been introduced from Gavi. And please already come up and take your seat as I call your name. She's Director of Public Policy Engagement at Gavi, the Vaccine Alliance, based in Geneva. She leads Gavi's advocacy to advance vaccine equity and the sustainability of immunization. So we are really looking forward to hearing how that equity dimension includes persons with disabilities as well. Then I have Dr. Karen Reyes, is Senior Program Manager at ATscale, which was mentioned a couple of times, an awesome organization. Take a look at their work, where she oversees global initiatives to expand access to assistive technology. A medical doctor and surgeon by training, she, after a spinal cord injury, transitioned from clinical practice to public health, becoming a strong advocate for disability inclusion and assistive technology. Thanks so much for joining us, Karen. And finally, we have Abaya Gujo Desta, who is Executive Director at the Federation of Ethiopian Association of Persons with Disabilities and board member of several civil society, Paralympic, and health organizations. Thank you so much. And I will free up some space for you as well. Yeah, sorry, I'm just going to move over. All right, bear with us. We, oops, sorry. All right, we had some accessibility issues with the venue, as you can see, to make sure there's a sufficient space for all of our speakers to feel comfortable and sit with us. Yeah, I'm going to start with Dr. Ebere Okereke's video statement. So we're going to hear what her organization is already doing or planning to do to promote health equity for persons with disabilities. So I would ask the organizers to show her a brief video intervention. Thank you.
Good afternoon. Please accept my apologies for not being with you in Berlin in person today. Thank you to the World Health Summit organizers and the session chair for inviting me to join this important conversation. I'm grateful for the opportunity to share the perspective of the Mohammed bin Zayed Foundation for Humanity on this important topic. So, the question you asked me was what the Mohammed bin Zayed Foundation for Humanity is doing to promote health equity for people with persons with disabilities. At the foundation, we see disability as inclusion as central to our mission on health equity. It's not a side issue for us. 1 in 6 people globally live with disabilities, as we heard earlier in this session, yet they are consistently left behind in access to care. They are less likely to be vaccinated, less likely to receive screening or treatment for chronic diseases, are more likely to experience preventable illness and early deaths. And this is unacceptable, and more importantly, this is actually avoidable. So our approach focuses on 3 areas. First, the evidence. We can't fix what we can't measure. So most countries lack reliable data on disability, and without it, planning and accountability are impossible. We are supporting the Lancet Commission on Disability and Health to close that gap. The Commission will generate the evidence governments and funders need to design inclusive systems. And secondly, we're embedding inclusion into all our programs. Every program we fund will collect data disaggregated by disability. We will expect our partners to make services accessible both physically, financially, and socially. And third, we're using philanthropy's flexibility to act early. We can take first risks, we can fund data systems and test inclusive models, and then we can work with governments to take them to scale. The UAE's experience hosting the Special Olympics showed that inclusion drives change. It drives change across the whole system. It has influenced national policy and made inclusion tangible across all sectors in the country. So the foundation takes the same principle to guide its investments. We must make inclusion visible, measurable, and achievable. And we're building the data, setting the expectation, and proving that inclusion strengthens health systems for everyone. Thank you.
I wanted to make sure Karen is not alone, so bear with me as I navigate around the stage. Thank you so much, Abera, and it's so important to have foundations and philanthropies and funders in this space as well. It is one of the most underfunded areas of official development assistance, also of humanitarian aid and of social policy. So we've heard about the commitments of the 15% from the Global Disabilities Summit and the Amman Declaration. We need more funders to walk the talk and support the important work as well, in addition to domestic financing. So second, I will ask Anna Maria from Gavi, the Vaccine Alliance, the same question. What is Gavi doing in this space? How are you ensuring immunization and health equity also for persons with disabilities?
First of all, thank you so much for the invitation. I hope everybody knows what Gavi is, but if you don't, I will just try to give you an overview in 10 seconds, perhaps. So Gavi is a private-public partnership, started in year 2000, and we are an alliance. So we work with core partners like WHO and UNICEF, as well as the World Bank and the Gates Foundation, and we have a multi-sectorial board that decides where the funding goes. Since our inception in year 2000, we have supported countries to vaccinate 1.2 billion children and saving 17 million lives. And I'm very proud to say that. We'll continue. And also to say that health equity and vaccine equity is at the core of our mission. However, to be very honest, we don't have criteria to include people with disabilities. So I'm really grateful for the invitation to this event, because I hope it's the start of a much bigger and better integration and relationship with the people with disability movement. So we know that there is an immunization gap of 14% between children who receive vaccination with disabilities and without disabilities. we also know that there is an intersectionality that needs to be applied. So Gavi has a number of policies and investments to achieve health equity. For instance, we have a gender policy, and we know that unfortunately the level of violence suffered by people with disabilities is higher, having women and girls with disabilities exposed 3 times more to the risk of rape than anybody else. We do need to acknowledge that. It's a very serious issue. And so we have part of our mission is also to reach, as part of the health equity approach, to reach the zero-dose children, which are the children in the world with no one single vaccine received in their lives. At the moment, there are 14.3 million children. Many of them, I think it's about 50% of them, living in fragile and humanitarian contexts. And but we need to apply the disability lens to that prioritization. So we have a specific investments on zero-dose children, and we also, as part of our next strategic period, are starting to implement the fragile and humanitarian strategy. So we have a lot of opportunities, but I need to acknowledge and be honest that we must do better.
Thank you, Anna Maria, also for being so honest. It's not always common on panels. So yeah, I think there are so many different levels that you spoke about, especially intersectionality. We all not only see the gender dimension in health systems that we're aware of, but also in disability. There are more women who have disabilities and more women who face challenges accessing services that are even available to the population groups. So really important areas. You mentioned humanitarian and conflict settings, really starting to impact the complexities and the multiple intersectional approaches we need to take. Thank you so much. I'm going to move to Karen and ask about ATscale and what you are doing in this space.
Thank you, Katri, and greetings, everyone. And I'll do a step back first. Because when we speak about assistive technology, we need to understand that it's not only about products. We need to understand that assistive technology is an umbrella term for products, for services that help and improve people to remain functionality, to being independent, and to improve their well-being. Such as a wheelchair. A wheelchair brings the person to the clinic. Hearing aids makes a consultation meaningful. Communication devices, such as speech-to-text, bring a voice to care. Disability, it's about being human. And access to assistive technology is essential to realizing human rights. It's a bridge between the right to health and the reality of accessing it. And because persons with disability face greater barriers to health, to services, assistive technology helps bridge that gap, enabling access, participation, and autonomy. Yet today, 9 out of 10 people in low-income countries don't have access to it. And that is not a technical failure, it's an equity failure. At ATscale, the Global Partnership for Assistive Technology, hosted by UNOPS, our mission is to close that gap. It's making assistive technology available, affordable, accessible through strengthening system, smarter investments, shared accountability, and advocacy in low and middle income countries. We bring together governments, United Nations agencies, donors, society, private sector to integrate assistive technology within the national systems. Let me give you an example to that. I'm happy to share that we're launching this month a national program in 7 Pacific Island countries. And the focus of this one, it's on school-age children, is to ensure that early identification for hearing, vision, and mobility for every child, it's in place. And it's not just about the products again. It's ensuring that the child has the care and the referral system they need. ATscale is a strengthening health system, including workforce capacity, from data to referral pathways, to service deliveries and maintenance, supporting procurement and regional supply chains, and fostering cross-fertilization across regions, so the knowledge and expertise circulates across the Pacific Islands and in general. This new initiative from WHO aims to close the health gap for persons with disabilities. And assistive technology, it's a piece of that. Assistive technology enables access to prevention, to treatment, rehabilitation, and appropriate care, improves outcomes, and reduces premature mortality, strengthens systems through inclusive data, trained workforce, and equality of financing. And that's why we believe this global initiative is so timely, and why we see that this global movement is a call to action for all of us here, and not just, we're just here listening, but it's our role to also amplify the message and join the movement. In this movement, assistive technology actors are connectors, bridging disability inclusion and supporting mainstreaming health. When assistive technology is built into systems design, health system comes stronger, more resilient, and more equitable for everyone. Thank you.
Thank you so much, Karen, and a beautiful example of remembering to speak at a speed that is readable for screen readers. Something, a little thing I wasn't aware of before working in this field as well. Thank you so much for emphasizing it's not just about the products, it's about services, it's about reaching the populations, things like referral systems, about awareness, right? Very, very important points. So thank you so much. We'll hear a bit more about that later. I'm going to move to Aibaine because I would love to hear what you are doing in Ethiopia and how you're approaching this in your space.
Thank you very much. My name is Abaina. I'm from Ethiopia. I'm the lead for the OPD umbrella we call Federation of Ethiopian Association of Persons with Disabilities. I'm serving as an executive director for last more than 8 years in the Federation and collaborating with governments and development actors as well as private sectors as well to enhance and ensure the inclusion of persons with disabilities in every aspect in the country. Just to give you a few pictures about Ethiopia, Ethiopia is a special country in the world by counting 13 months per year. And also we have currently over 23 million people with disabilities in Ethiopia. By saying this, maybe as an OPD and civil society group, we are facing many challenges to ensure inclusion of persons with disabilities in every aspect, especially when we look the participation of persons with disabilities in the social inclusion aspects and the economic and the political participation as well. But the most important thing we need to know is why we have a limitation and participation of persons with disabilities to see the inclusive global world. So, because of two main reasons. One is the neglecting or the understanding level of people in general in Ethiopia is too back than comparatively with the global community because of the many reasons. One, the commitment of the government to tell for their people about disability was been very limited. So today I want to say the most important thing here is that the commitment of government, the commitment of development agents, and the commitment of public sector as well should have to be clear to enhance the capacity of OPDs as well as the understanding level of general community about disability and its limitation. I think the second one is very important thing is we lack having policies and instruments that direct or force government as well as the general community to focus on people with disability engagements and participations. So to break this, still we need to focus on which kind of policies and where it brings a good example to this country, to bring it and to see. Because Ethiopia at this moment, as I mentioned to you, with huge population, more than 113 million people were been living in Ethiopia with this huge population, but Ethiopia have unluckily have no disability policy at this time. So without disability policy, we are struggling a lot. And also, Ethiopia have no clear picture that where to go to ensure inclusion of persons with disability. Just we are struggling as before 15 years, Ethiopia is one of the country ratified UN Convention on the Rights of Persons with Disabilities, and just we are relying as an advocacy instrument only that document, but they didn't even cascade it to the country level as well. Besides saying this, still from the general community, besides the awareness, also when to see the gap between people with disabilities and the general community as well is very big now. When you go to education sector, they have last year report which clearly shows us for only 4% of the people with disability, those have school age, were being in board. The rest of 96 were not getting a chance to learn. This is clearly from the Ministry of Education report. So this shows that where we are going tomorrow, because by dropping one and hanging the other will not be bringing a global change. This is what I can say. From the education, I mean from the health sector, many of things were been improving, but still jumping disability agenda in many cases. Of course, with the WHO program, we learned that a lot of things are coming up through Ministry of Health. Especially we started developing the instruments like the checklists and guidelines and something like that. But as I mentioned earlier, there was no clear policy direction as in a country, which means without policy or without political commitment in Africa especially, we will not bring a change. So that's why things were been wasting our time and just fatigue and within the policy and within the development thinkers. As a Federation of Ethiopian Persons with Disability umbrella organization of all OPDs in the country, we were been also actually a member for ADF as well, Africa Disability Forum. Through ADF, we also a member for Alliance, as I mean IDA as well. The most important thing you have to understand is we're clearly working with all means to enhance the capacity of persons with disabilities. By saying this, maybe as a federation, we also closely working so far with a CBM to see the OPD's capacity should have to be enhanced to advocate their own agenda by themselves. So we were been doing a lot from this part, as well as also to ensure inclusive health, ensure inclusive education services, livelihoods for persons with disabilities. Also, we were working with HI as well, clearly how to find the things, challenge areas to bring to government as well. So today, I just want to ask the general world communities through this channel that to see the commitment of government should have to be balanced in the world to ensure inclusion of persons with disabilities. Thank you.
Thank you so much, Abene. And very important to remember, so much of the work in low and middle income countries happens at country level. It happens at community level. It happens through organizations such as organizations with people with disabilities. It's not just the global entities in Washington, Geneva, and others. So really, really important perspectives. We are slightly over time, so I'm going to ask the panelists here in person to think of one sentence how they are going to engage in the Global Health Equity Initiative. And we will take Dr. Ibarra's video statement while the panelists here in the room wait. So thank you.
Thank you for this question. So you've asked how we at the Mohammed bin Zayed Foundation for Humanity contribute to the global movement for health equity for persons with disabilities. First, for the movement to succeed, inclusion must move from the margins to the mainstream of health policy. And our role at the foundation is to help make this happen. So first, we use our voice, our convening power, and our partnerships to raise visibility. Disability inclusion must be part of the universal health coverage agenda. And when it becomes visible at the political level, we believe that more resources and accountability will follow. And then second, we will invest ourselves in generating the evidence and developing the accountability. We need proof of what works, what it costs, and what returns that investment brings. Inclusive health systems save lives. That is what we believe. They improve productivity and they strengthen societies as a whole. When that evidence is clear, investments should follow. And third, we will work directly with countries. The Foundation has always had a preference for engaging directly with governments, believing strongly in their responsibilities to optimize the health experiences of their communities. So we will support governments to adopt and scale inclusive models of care through training, accessible infrastructure, and better data systems. We will fund initiatives that place people with disabilities at the center of decisions. Real inclusion isn't just about collecting the statistics. It only happens when the people who are affected by disabilities lead the shaping of the solutions. And philanthropy has a catalytic role to play first. We can go first, we can de-risk new approaches, we can build the evidence base that then enables others to follow. At the Mohammed bin Zayed Foundation for Humanity, our commitment is to make inclusion part of how all health systems function, not as an afterthought. We will help to measure it, we will fund it, and we will share what works. And it's only then that we can move from the intention and aspiration to real impact and ensure that no one is left behind. Thank you.
Anna Maria, I'm going to give you a difficult challenge. One sentence, what is Gavi, the Vaccine Alliance, going to do as part of the Health Equity Initiative?
Can be a long sentence.
Be a longer sentence.
We must, in Gavi, understand that health equity is not going to be achieved if we don't include people with disabilities. And we must make, I continue the same sentence, and we must make that concept a reality in our funding applications. We should include criteria when contra applications about how people with disabilities are included, from the access to immunization to the training of community and health workers, to the political will of local communities and governments to invest in immunization for people with disabilities inclusion. Long sentence, but I
Thank
think
you
it's
so
good.
much. Wonderful. And thank you for being so practical as well. That's very, very granular and a great way forward. Abane, I'm going to move to you. What are you going to do as part of the Health Equity Initiative?
Okay, thank you. I think making one sentence is difficult for me, to be honest, but we'll try. The first thing we need to understand very well is our 2030 agenda, where it is now and how long we worked over it and where we are now to finish. But from the side of disability inclusion in the health sector, from the quote of 2030 agenda, no one left behind, where we are now. We need to understand this very well. And so this is a time now. We need to use our last effort to ensure inclusion of persons with disabilities. From our side, we are doing a lot, pushing the government to have disability policy, pushing the government, advocating on the issue of the inclusion of persons with disability. Instruments should have to be strong, instruments should have to be come up and institutionalized. The issue should be institutionalized. Without that, we're going to not be achieve things like whatever it is. And also, we really not want to rely only one or two organizations which are supporting disability movement nowadays in Ethiopia, but all private sectors, all the international NGOs, including the WHO by itself, was been responsible to ensure their commitment equally to distribute for all in needy countries. Thank you.
Thank you so much. And thanks for emphasizing the point of integrating and institutionalizing policies. It's so important for sustainability and to make sure we're taking these issues to scale. Karen, the last challenge is yours.
I promise I'll speed up.
No, don't speed up, but yeah, try to
But
stick to time.
what ATscale will continue doing, it's our strategy. 3 key elements: country support, global enablers, meaning working together with WHO, IDA, UNICEF, bringing what we know it works to scale. And third, advocacy. We cannot do this work without awareness raising, and more important into this, bringing the user, bringing people with disabilities voice to the table. Thank you.
Thank you. Thank you so much. Very clear points. And also to any funders in the room, if disability inclusion is underfunded in this space, the worst funding is for advocacy. So do try to fund the advocacy space. We've heard about shrinking civil society spaces. It's really important that we're able to continue this work, whether it's at European level, in Africa, any region we work in. Do try to support organizations who are working here. I'm going to grab the mic and also run 1 or 2 last Mentimeter questions, which are already up. All right, so this is a question to you. It was a call to action for everybody to engage and join. Leading from where you are, what's one action you could take tomorrow or today to bridge the disability inclusion gap? So repeating the question, from where you are today, what's one action you could take to bridge the disability inclusion gap? Advocacy, being present and speaking about my experience, advocacy raising awareness, advocating for the people that do not have a voice, advocating for inclusive healthcare, co-designing is really important as well, enhancing the education of healthcare professions, bring testimony from field projects. Miriam, if you can scroll down a bit, I can then see more of the responsive as that's possible. Okay, perfect. Coordination, more ways, awareness raising to health professionals globally, supporting developing tools, practical applications, ensuring people with disabilities lead policy decisions. I think that's so important. Don't just invite people to speak, ask them to lead. Include it into the proposal you will submit. Very practical and incredibly granular. Thank you. Promoting inclusive education and community awareness to ensure equal opportunities for persons with disabilities. We'll collate these and try to add them to the summary, but as we can see, there's a richness already of so many actions we can take together as a community, no matter where you're sitting from. Okay, let's move to the next question. And then I would love to open up for a few questions from the audience as well. If you had to describe what bridging the gap looks like with one emoji, what would it be? You can click a text box and select your preferred emoji from your phone. Get creative. What does bridging the gap mean? Oh dear. Yes, some muscle, love, a puzzle piece, togetherness. Maybe that's empathy. I'm not sure about that emoji. I have to ask. Celebration, maybe a moonshot. Great. Togetherness, global. A hug. Wonderful. An exploding head. Yes, it's good to be very explicit as well. You can express without filter. Okay. I would love to spend just a few minutes. I would love to maximize this time in all the sessions, but unfortunately we do need to move to the closing remarks. We have Jose Vieira here with us today, and the World Health Summit is very strict on our session times as well. So I have a hand make. I'll come over and see if there are any questions in the audience. Okay, I'll start here in the middle, and then if you can hand the mic back to Rose.
Okay, thank you so much. My name is Lay. I am a medical student from Iraq, and I'm here to represent the International Federation of Medical Students Association. We are here representing 1.5 million students, medical students worldwide. So my question is, as medical students and as part of the civil society, how do you think we can be included in the inclusivity of people with disability, especially at the community and primary healthcare level? And thank you so much.
Thank you. And I had a question here in the back. I think it was you.
Thank you for such a great presentation. My name is Sheila. I'm a speech and language therapist by background, and I'm part of the GA Prevent NCD. My question is, there's a lot of focus on physical disability and a lot of funding towards physical disability, and this is really valuable. However, from my work, I know the importance of communication disability and how people with communication disability are often really excluded from healthcare decision making. My question is, what will the WHO do in terms of empowering people with communication disability to be included? I know there's an action policy on assistive technology, and that's really welcome, but what would the actions be? Thank you.
All right. Keeping with time, there are two questions. So I'm going to give the one on WHO to Daryl. So if we can start there.
The short answer is we don't put a focus, certainly my team and the health equity work, we don't put a focus on any one underlying impairment group, right? We recognize that though certain impairments, people with a range of physical or sensory impairments might seem to dominate, I guess, like how you've put it. I think for us, we're whenever we do country work, we're always conscious to make sure there's representation across the board. People who are deaf, people who have intellectual disability, a range of different stakeholders. For us, we're more concerned with the barriers in the system rather than the underlying health condition. It's going to take time, and I recognise and agree with you that there is a dominance in certain spaces, but it's something we're very conscious of, but it's going to take us a little while to turn that around.
Thank you so much, Daryl. And from the medical student sides, I'd love to ask, Anna Maria or Bene, would you like to respond? How do we include and make sure medical students are also brought into this? Yeah, Bene.
Yeah, thank you. Maybe I can say something because as a Federation of Ethiopian Associations of Persons with Disabilities, as you see from myself, I'm a physical disability, but that means not I'm working as a federation for only persons with disability. I mean physical disabilities, but across all disability type we're been as an umbrella OPD. We, for instance, we in Ethiopia have National Blind Association, which has been the founder for this federation, and National Deaf Association, which has been the same, and also National Physical Association by itself has been a part of the founder, and we have a National Intellectual Association, Deaf Blind Associations, even we have a Women with Disability as national associations as well. And also we have different types of autisms and intellectual disability types were being there. And also even we have a national association for leprosy affected people with disabilities. As you know, leprosy by itself is a health issue. And ultimately, when you recover from the disease, then you're going to be faced one or two more type of permanent disability types. So these all are in a group, and we represent all. But from the question point, maybe I have also some suggestion for the organizers for the future. Maybe representative of each disability type will be here, and this kind of conference will I agree. Thank you.
Thank you so much. And thanks for great questions. As you've heard, there is so much engagement at national, community, and regional and global level. I think part of the problem is also the fragmentation in those spaces. So coming together, for example, also in the WHO-led Health Equity Initiative is really important so that we are pulling together the community and all of our collective voice in one space. I am super happy to come to the closing remarks. I am sure they will be powerful, and I've heard Jose speak a couple of times before. Jose Vera is Executive Director of the International Disability Alliance, the International Disability Association, with 20 years of experience in the disability movement. He previously served as the Chief Executive Officer of the World Blind Union and is based in Canada. And as we heard, was one of the co-organizers of the very important Global Disability Summit that took place in Berlin earlier this year. Over to you, Jose.
Thank you, Katrin. Good morning, colleagues and friends. I have the great honor and in a way the responsibility to provide closing remarks. And we have heard not only great interventions, but I would say even more impactful reminders of what we have to do next. When we talk about inclusion, it's quite often to hear that is the moral and smart thing to do. That by promoting inclusion, countries can increase their GDP up to by 7%. Or that person with disabilities and their families represents an estimate market volume of 13 trillion American dollars. But when it comes to health equity, it's not just the smart or the moral thing to do, but the urgent thing to do. Let me repeat it, the urgent. Are we all clear about what Daryl said, that we, persons with disabilities, are more likely to die 20 years earlier than the rest of the world? Did you hear that? What was your reaction? Can we take it lightly? We cannot. How much longer are we going to tolerate that women with disabilities, women with physical disabilities pregnant, have to go for an ultrasound to a farm instead to a hospital, because hospital test machines are not accessible? How long are we going to tolerate that a deaf person is basically invited to leave the health facility by a health worker because the person cannot communicate? How long are we going to tolerate that a blind woman hears the doctor saying, "Why did you get pregnant? Who's going to take care of your child? Why did you come alone to the appointment?" I do have a daughter, and once I took her to the doctor appointment because my wife said, "It's your term. You're a daddy, it's your term. I'm busy. I want to watch a movie." I went there, and the doctor said, "Did you come alone? Who's gonna take care of your child?" Me? Why not? So stories like this are millions. And we hope that the next time we gather here, the millions of stories that I can share are those that reflect inclusion. Deaf people being able to communicate and get the information. Women with physical disability pregnant have the same right of every other woman to give birth. The solution is rather simple. I think we need to be clear that what we are asking for and advocating for is not impossible. The solution is simple: political commitment and right investments. Hello, once again, political commitment and smart investments. Nothing else. If there is money for words, if there is money for weapons, there should be money for health. There should be money for health and inclusive health. The global initiative that the WHO launched is the pathway, is the clear pathway, the exact combination of persons with disabilities in the center, the global system bringing us together, and the rest of the health stakeholders working behind one common goal, and that is to promote inclusion. There is one more thing that we cannot forget. The only way to bring people with disabilities to the table is through ensuring meaningful participation. And our colleague from Ethiopia was very clear. And he is in the front line. He's not in Geneva, he's not in New York, he's not in Washington, he's right there, where persons with disabilities need us. And he said it loud and clear: enhance, invest, promote, finance organization of persons with disabilities if we want to see a sustainable change. Colleagues and friends, I have no more time, but I do have a commitment, and the commitment that it must be yours as well. The next time that we gather here, we should be more, and we should not be only talking in this session, but talking across the whole summit. Take a look at the program. Take a look at the program, and I bet you to tell me if there is more than 2 sessions that talks about disability inclusion. I invite dinner. Next year, the next summit, at least 10 sessions where we are present. Thank you.
Thank you so much, Jose. As expected, Jose is so articulate and just nails it with his remarks. Thank you for being here. That was a clear call to action, not only for the World Health Summit, but for all of these kind of convenings. not just one session, not in the most remote room, not in the smallest room. There is so much interest, and it is 1 in 6 people that we're talking about. Again, if you count psychosocial and mental disabilities into that equation, we're nearly at half of the global population. That cannot just be one side session. So thank you for being here. I hope you will agree this was the best session of the whole World Health Summit. Give us feedback, keep engaging, and social media. Thank you.